Hello, hi, how are you? Welcome back into a special edition, a live podcast by George. The reason I wanted to do this live is because things are happening so quickly and changing that everything gets outdated before I can get it published almost. In particular, with the COVID-19, the coronavirus, and what's happening right now. The president and first lady are in quarantine in the White House. Hope Hicks has it. Mike Pence is on standby, I think. People are making preparations for a possible change at the head of the government temporarily if Trump gets real sick. They describe it as pandemonium in the White House. And my God. And I thought, we got to get our friend, our good doctor, Andrew Nish, back on the podcast. Now, he's the head of the John Stoddard Medical Center. He's very knowledgeable about all things medical, but of course, he's been helping us out understand this COVID-19 situation from the very beginning. And in some instances, it's changed a lot here in just the last day or two as far as the news cycle is concerned. But in other ways, the fundamentals remain the same for all the rest of us. So let's bring him on in here. Doc, welcome back to a podcast by George.
Thanks, George. Nice to be here this afternoon.
I thought about bringing you on and discussing the situation with you. And you and I have never talked about this, but I've thought about it before when it comes to doctors, and kind of put it in the context of a cigarette smoker, somebody that is using tobacco products, and they come and see you regularly. You're their doctor, and every time you see me, you got to quit. You got to cut back. They can't do it. They won't do it. And then one day they show up at your office and they've got it. They've got a lung cancer. They've got something caused by cigarette smoking. And now, you're going to do what you can. You got to deal with it. But here's this patient that it could have been avoided if they'd have been able to do what you had advised all along. And I don't know, do you feel in that circumstance as a physician, a sense of frustration, a sense of disappointment? How do you deal or cope with those types of feelings?
That's a great philosophical question. I'm going to tell you, early in my career, I would have kind of blamed the patient and really laid it on them. But as I've evolved in my career and as I've evolved in my knowledge, I look at that patient with empathy and really wonder, why did they start smoking in the beginning? Because smoking is a surrogate for something else they're missing in their life. So it's a coping mechanism. And we have treated smoking, we have treated drug addiction, alcohol addiction, and all these other addictions with the mantra of personal responsibility. But I'll tell you, when you delve into these people's past and you delve into their childhood and the traumatic events that have shaped their lives, you can understand that all of these things are not their fault. They're coping mechanisms for what they've gone through in life. And so I've been very empathetic with a smoker who can't quit. I want to know what in your life are cigarettes substituting for? Love, affection, acceptance. It's the same with any addiction. They're using that substance, they're using that habitual behavior to cope with something that happened traumatically early in their life. So, you know what? I encourage people, of course, to stop smoking, but I can't make anybody do anything. I can only work with a patient in a guiding manner and let that patient come up with reasons they might want to quit and ways they might want to try and quit. So it really is about empathy for that person and really understanding their story. Because our stories are a critical part of who we are later in life, and not just who we are as a human being, but who we are as what diseases do we have? It's really amazing, George. We've looked at medicine as we're just these biochemical machines, and we fix a chemical and everything's good, and it is just not true. Herbert Benson from Harvard wrote back 50 years ago, 90% of all office visits are stress and trauma related. 90%. So not only are we using cigarettes to cope with our past traumas and lives, we're using alcohol, we're using drugs, we're using food, we're using sex, we're using violence. We're using all these things to cope with where we are in life. And so instead of telling people, well, it's your personal responsibility, we need to help people change their story.
Well, it makes me wonder because we've got this circumstance right now in my mind, which is kind of substituting tobacco as an example for the COVID-19 circumstance that Donald Trump finds himself in. His tobacco, so to speak, appears to me to be politics. I mean, as a physician, you can tell people to wear a mask. You can tell them to wear it to social distance. And if they don't do it, they're putting themselves at risk. And then someday they come down sick. Now, when you think about Donald Trump, I know you don't follow the news as closely as I do, and good for you. It's probably the best for you. But I mean, this can't be a surprise or a shock to you as to what's occurring based on what you've seen.
No, it's not a shock at all. I think what it does, though, George, is it points out that there are no social, economic, cultural barriers to COVID-19. It has no boundaries. So whether you're in the White House or whether you're in the slums of Chicago or New York, you're susceptible. And, I think it really highlights the fact that no one is immune unless you've had it before, and you may have immunity, but I'm just saying in our general population. And it goes back to, again, what we've talked about multiple times is recommended good public hygiene, hand washing, face masking, physical distancing, okay? Taking care of our bodies, taking care of ourselves. Why do we have this incredible infection rate in this country? Because we have so many chronic comorbid diseases. So we know that people who have high blood pressure, obesity, diabetes, heart disease, cancer, all these people are more susceptible to the virus and the severe effects of the virus than if we were healthier. And this is really highlighting the poor health of our nation in general, but it's dramatically highlighted the racial disparity in health. So I was just watching a thing this morning from Dr. Fauci. It was the Harvard Morbidity and Mortality Conference. And they looked at severe cases of COVID-19 per 100,000 population. I think that was the measure. African Americans were almost five times more likely to be severely affected by COVID than non-African American whites. I mean, it's startling. It's not even close. So there were 331 African Americans who were severely ill. I think it was per 100,000. And when you compared that with whites, it was 71. So we've got a huge societal problem. And not only do we have economic discrepancy, we have health discrepancy. And I go back to, our traumas and our stories and how that makes us more susceptible. And our African-American colleagues, our African-American brothers and sisters are carrying around traumatic baggage that goes back to slavery. And this impacts health. And this is a wake-up moment for this country. We have to be better.
Agreed. And some of that undoubtedly has to be socioeconomic, as you mentioned, folks that are having to live in closer quarters, having to live indoors more, not having access to the great outdoors, as an example, closer proximity to others, including family members. They're much more prone to get this virus. And from what I'm seeing, it appears that there's becoming an increasing understanding of the aerosol part of this. I think they call it aerosol, but the airborne part of this. Now, correct me if I'm wrong, but when this thing first came down, there was a lot of emphasis on the hand washing element, not as much on the masks originally. Now there is a lot on the mask, but I read something recently where they said it's like if you can smell someone's cologne, or if someone is, I've pulled up at a four-way stop at an intersection in a car with my window down and smelled the cigarette smoke from the driver that was at the intersection before me. I mean, honest to God, that's how sensitive I am to cigarette smoke because I don't smoke. Well, if you can smell those things outdoors like that, you would also be subject to getting infected by COVID because it moves through the air in the same way that those things do, colognes and smoke?
Yeah, let's go back. I want to go back and comment on sort of the socioeconomic disadvantage.
Yeah.
There's kind of a double whammy for those people. Number one, they have a higher incidence of chronic diseases like we've talked about, high blood pressure and obesity and diabetes. But number two, they also work in industries that are much more prone to transmitting the COVID virus.
Meat packing.
So they're packed into meat packing, they're packed into
Yeah.
factories. And so they are in industries that have a much higher rate of infection. And so they're really getting hit hard because of that. Now let's talk about this whole aerosolization thing.
Yeah.
So smoke is different than the particles from COVID, okay? So like you can take an N95 respirator, and if you were in California where all the fires were, that is not very helpful for smoke. Those particles are even smaller. But, we thought that particles less or greater than 5 microns in diameter fell to the ground very quickly. Well, the particle physicists, and I don't mean the atomic particle physicists, but the physicists who study aerosolization and droplets and things are telling us that this 5 micron thing is not holding true, that even particles larger than 5 microns can stay suspended in air for a period of time.
Yeah.
So it's not as simple as, oh, big particles drop to the floor really quickly and small ones don't. We're learning more and more about this, and that even the bigger particles bigger than 5 microns are staying airborne for a period of time. And so that's why physical distancing, I don't like social distancing, is important because, there are particles that are going to drop quickly, but some of those particles are going to stay in air, and that's why masks become so important.
Indoors, mostly, right?
Indoors mostly, but if you're in a crowded situation outdoors where you can't distance 6 feet, you should wear a mask.
Yeah.
But if you can distance 6 feet and you're outside where there's infinite air exchange, I would still recommend, if you want to be safe, wear a mask. Outside, it's okay. Wear a mask. We all have to get used to this.
It reminded me the mask wearing, they had them social distance, supposedly, spaced during the presidential debates. Biden at one podium, Trump at the other. But they were indoors, and I think they were 12 feet apart. And some people not too long ago would have said, well, that's safe. I mean, they were more than 6 feet apart. They were 12 feet apart. They're okay. But if those particles can waft around in the air like you're talking about, indoors particularly, nobody's safe. Now, I saw another interesting thing I wanted to ask you about because I know you're a big proponent of masks, and rightfully so. There was that, I can't think what his name is now, but the expert that was on television this past week, he said that masks are the best vaccine that you can get. And he might have meant even in the future. Will masks always be a better protector from a COVID virus than even a vaccine, or is it reasonable to expect someday we're going to get a vaccine that will be even more preventative than mask wearing?
Depends on how effective the vaccine is. So he could be correct. If we develop a vaccine that's only 50% effective, that means you only have a 50-50 chance of being protected. You're much better off wearing a mask.
Are you? Yeah.
So I think the question is, we don't know. And I'm kind of glad you brought up vaccines because people are like, oh, we're going to have a vaccine in a month. We're not going to have a vaccine in a month, okay? Moderna came out today and said, and they're one of the, they're well into a phase 3 trial, said, don't expect mass delivery of a vaccine the earliest of March of 2021. So I love how the mind-body connection and how we think and how that affects our lives. And so what I want to do is I want to prepare people that, you know what, we need to be prepared as a country, as a society, as the world to continue current policy of masking, physical distancing, hand hygiene. And we need to be prepared to do that for at least another 9 to 12 months. Because in your mind, if you have the thought process of yeah, this is going to be another 9 to 12 months, and you prepare your mind that way. If we get a vaccine earlier, guess what? That can only be good, right? But if we prepare our minds, oh, we're going to have a vaccine, by the end of the year, and then 6 months later, we still don't have a vaccine, that can wreak havoc with your anxiety and your body. So it's really about messaging and expectations. And so I want to tell people, do not expect a widespread vaccination program for at least 9 to 12 months.
You mentioned that Moderna, that article, that vaccine that they were talking about. I wanted to ask you about that specifically. 'Cause I struggle with this stuff, Doc. I mean, I listen to you and I think I get it. And then as soon as we're done talking, I have questions. I read that article real closely, and that one of the elements of that vaccine that they're really excited about is the fact that it improves the immunity of older people as much as younger people, and they were really excited about that. And I got to reading it, and what this vaccine is, the Moderna, or at least one of them that they're working on, is an immunity booster, kind of overall, as opposed to what I would think of a vaccine, which is a shot that you get that keeps you from getting a specific disease of some type, like measles or polio or something like that. But that's an immunity booster to me, as opposed to a vaccine. I mean, where am I getting confused here? Yeah.
Yeah. I mean, there's different parts to our immune system. And so what we're looking at with these vaccines is our immune system producing antibodies, which will negate the virus. And yes, the Moderna vaccine is producing antibodies against the virus. And yes, there are fairly high titers, even in elderly people. But beyond that, we also need to be looking at cellular immunity, so T cells. So we haven't even looked at that yet. Are we producing T cells that will keep us immune from that vaccine? So T cells are the cells that come and gobble up, viruses and bacteria and things like that. So we're changing. We're developing our immune system to recognize and immediately fight off this virus.
This virus.
So
as opposed to like this virus and a cold, for instance. It's specific.
This is not going to change you getting a cold. You know what's going to change you getting a cold? Wearing a mask all the time.
Doing the right thing. Washing your hands. It's the same thing, sure.
This is going to be fascinating this winter, because never before in the history of this country has anybody masked during the flu season. And now let's say 40% of people mask, because we're still less than 50% of people masking. If we see 40% of people masking, then we should see a concomitant decrease in the amount of flu, I would think. And so it's going to be really fascinating to look at the data as we go through the next flu season. Me personally, I would expect with physical distancing and masking that we would see a significant decrease in flu.
I already got a flu shot.
Get your flu shot.
I got one.
I mean,
I got to tell people this. Now I've been getting them since they came out with them, basically. And I always tell the story. I think in the 80s was the first time I'd heard of a flu shot. I was working on the news desk at WHO, and a lot of the reporters down there were scared to get a flu shot. Bob Wilbanks, the gunny sergeant down there that ran the newsroom, gotta love Bob Wilbanks, tough old guy, these reporters wouldn't get a flu shot. And he said, he walked through the newsroom, he said, my God, of course, he wanted them to be well. He wanted them to come to work. He said, you guys leave here and you drink and smoke and you do all of this stuff and you won't take a flu shot. He says, honest to God. And back then they were what I would call invasive. I mean, you got a flu shot, you kind of knew it. It was a pretty good sized needle, it seems like. And, you knew that you got a shot. Well, I got a flu shot this year, Doc. Honest to God, I didn't think the gal at the Medicap had given me the shot. I mean, it wasn't even a skin prick. I mean, I literally almost couldn't feel it. How is that? How have they changed that shot so that it's like that now?
I don't know what it was like in the 80s, but they're just tiny little needles. They're, or what we call a 25 gauge needle. It's the same size needle you use to inject insulin. And, most people will get just a little tenderness at the injection site. A small percentage of people develop a fever or even body aches for 24 or 48 hours. But the side effects of these vaccinations, the flu vaccination, are pretty minimal.
I can't even tell I got it, literally. I mean,
That's what they're studying with the COVID-19 vaccine too. What are the side effects? We're seeing mild fevers and some body aches. But right now, except for when they stopped one of the trials in England, the trials are moving on. J&J just opened their trial, I think last week or the week before. They hope to enroll, or they will enroll 60,000 people. Their vaccine is interesting. It's different than the others. So the Moderna is based on what's called an RNA vaccine. Johnson & Johnson is called a viral vector vaccine. And the nice thing about the J&J vaccine is that it is doesn't have to be stored at 96 or something below zero. It can be stored in a refrigerator, and it's a single dose vaccine. Whereas these other ones are going to be 2-dose vaccines.
Yeah.
So, it's going to be fascinating watching this evolve. It is an evolution. I come on today, and like Mike Osterholm, he's the epidemiologist at the University of Minnesota. He comes on and says, hand me back in a few weeks and I'll tell you what I said wrong. We're all learning. Nothing I say is gospel. I'm doing the best I can with the science we know now. And what hasn't changed is the mask wearing, the physical distancing, and all these precautions. That hasn't changed. But the vaccines will evolve, treatments will evolve, and who knows what we'll be talking about in 3 weeks.
Talking about treatments, just based on kind of the protocol standard, if there is something approaching that for somebody that's just initially diagnosed with COVID-19, what's Trump going through right now? Just say he's a regular patient. What do they do? They start a regimen of that I can't even think what that drug is. Starts with an R or whatever. Do they give him that right away, or what happens?
No. So this is really interesting. We've used remdesivir and steroids in severely ill patients. So both of those have shown efficacy at improving the time to clinical improvement, but they've only been given in patients who are requiring oxygen or who are in the ICU.
Oh, in a bad way.
So we do not know in mildly symptomatic patients. We have no drugs as of this point that have proven efficacy in shortening the course of the disease or decreasing the mortality. So all the drugs you hear about are used in very sick people. But I'm sure, it's the president of the United States. They may try convalescent serum, which is basically we're giving you antibodies to the virus. There's some monoclonal antibody trials going on out there. I don't know, we don't know the status of those. We haven't seen peer-reviewed data on those yet. But there's some optimism that these monoclonal antibodies may be protective in mild cases, and we may be using those, but we don't know yet.
Well, I got to ask you before we get out of here now, before we end this podcast, this question I've got to ask because my wife makes me ask. We've got personal experience with the COVID-19. We've got a couple that's a friend of ours, elderly, 1st of May. They both came down with it. He almost died of it. And one of the reasons was he had an allergic reaction. And I mean, just really bad. They've been recovering very slowly. But she said, ask Dr. Nish about this long haul thing, or I think it's called long haul. Or anyway, they're still trying to get over this. They're in therapy now. Hell, we're in October from this May 1st infection that they got from COVID-19. Is that extremely unusual, or are there a lot of people that have gotten this that continue to have remnants of it, that have some symptoms for a long period of time?
Yeah, I would not say it's extremely unusual. It's not the norm. Most people recover, but there is a small percentage of people who they're calling them long haulers.
Yeah.
We don't know the exact percentage, and there's a lot of concern that younger people have these long haul symptoms. And those symptoms include chronic fatigue, chronic shortness of breath, neurologic symptoms, brain fog, can't think right, cardiac symptoms.
The younger people, did you say?
Mm-hmm.
Oh.
Yeah. A lot of younger people are in this long haul thing. But for a small percentage of those people who have acquired the COVID, it hits months. And we're learning. Again, we're learning. Is this permanent? Is there going to be full recovery? We don't know. And we're particularly concerned about cardiac abnormalities. So we're concerned about damage to the heart muscle. We're concerned about damage to the electrical system of the heart. And are these temporary changes or are these more permanent changes? And until we continue to study this over a longitudinal time frame, we don't know. We don't know. And we don't know the percentage of people that are in this long haul category.
Well, those friends of ours are, and I wish them well, and I hope they recover from it. I got to take us out of here. I guess what I would say in closing, and I'm just reminded of the fact when we first started this, Doc, you heard me say, don't get your information from a politician. Why? Look at Donald Trump. I mean, look at, honest to God, the last campaign stop that he had yesterday. He was telling people that it's about over with. It's exaggerated. Oh my God. Now he's down with it, and so is his wife. Don't get it from a podcaster. Get it from a medical practitioner. Get it from somebody like Dr. Nish. So I'm going to give you the last word.
From a medical practitioner.
Yeah. Give us the last word here, Doc, as we wrap up. You're good at the part of it that makes everybody kind of feel good going out the door here. Wrap us up here.
I'm going to wrap it up. So you'll notice I'm in my biking clothes because I was out, had to get a ride in today. And I really want to emphasize right now, this is an extraordinary time of year. Get outside, enjoy nature, and just enjoy the peacefulness of the fall time. I mean, it's an extraordinary time. If I looked at the weather next week, it's going to be in the 70s. It's going to be sunny. And, within a few weeks, we're going to be trapped inside, although you don't have to be, but get out and enjoy nature as much as you can. And as my adage is, I love to be outside no matter what. And so I just say, there's no such thing as bad weather. There's just bad gear.
That's great.
And it's kind of true. I mean, our outdoor gear is so good nowadays. You can stay warm, you can stay dry for at least a half hour to 45 minutes. And so some of my favorite time to be outside is a cold, wet, windy rain. Nobody else is out and you're the only idiot out there, but
I'm with you.
I'm out there, man.
I'm a hockey guy, man. I'm out on the bike trail. I've been doing 27 miles a day. I mean, which is all I can handle. I mean, that's all I need. And 27 miles is kind of a famous word around our house, or to term, because that's what I ride. So I'm out there with you. And same way. I kind of like the bad weather days. I mean, it's not as crowded and
get outside. Good. Nature is healing. Nature can calm you. And again, stay away from the television set.
Yeah. And here's a laugh for you. Maybe when somebody passes me, which happens every once in a while, because it's my bike, Doc. I don't have the fastest bike, but somebody passes me, or even when they come from the other direction, I don't wear a mask on my bike. I probably should.
I don't either. I do not wear a mask on the bike. Yeah. I'm moving pretty fast. Yeah. And
I hold my breath.
Okay.
when they go by me, because again, I think of that aerosol, whatever you call it, and I think of the perfume, I think of the smoke. If I can't breathe them, if I can't smell them, maybe I'm getting a little safer. I don't know, but anyway, God. All right, thanks, folks. That's Dr. Andrew Nish. He's the John Stoddard Medical Director. He's our expert really on COVID, and we love to have him back on the show. Doc, I wish you well. Ride safe and ride well, and we'll talk again soon.
Everyone have a great weekend and get outside. Thank you.
That's great. That's going to wrap it up, folks. That's going to do it for this live version of Podcast by George. Thanks for watching.